I may take from the chairperson, may take 10 minutes more. If time permits, please allow.
We are already late by around 15 minutes.
Okay. So I want another 10 minutes from my side.
Let me see.
Let's see.
Will you allow?
Because it's a good topic and today's scenario.
Another 10 minutes? No. They say no.
Okay.
Because we are already late. No, we do not want to be late. We have
Let's
to
see.
come.
So we were working through a challenging real-world pediatric respiratory cases to align our clinical diagnosis and decision. So with evidence-based guidelines led by me and our panelists, Dr. Yasin Ali, Dr. Himanshu Shekhar, Dr. Chao Nipseng, and Dr. Sognali Borwa. So our goal is to address common diagnostic pitfalls and our prescribing and learn how to identify critical red flag early. Likewise, already our motto is there, breathing better tomorrow. I say breathing better from today onwards. So let's start with a bit of history. In the ancient times, there is a cough were managed with simple natural demulcent like licorice root, resins, then your jujubes. These are boiled to create a soothing liquid, and it is fascinating to contrast this ancient approach with now modern practice. So where we often jump straight to complex over-the-counter cough syrups without clinical judgment. So with this idea, we start our session. So I want the case 1. This is 18 days old mother, baby cough 4 to 6 times in a day. Short bout of cough, sleeping well, sucking well, no fever. So I want to know the audience, will you treat this child? Anyone? Before going to the question to the panelists, whether we will treat the child or not. So I think Himanshu, please highlight this point, whether we will require any investigation or whether required treatment or not.
No treatment required, and I will not do any investigation.
Why? Mother is very anxious by whether my child is suffering from pneumonia or dhai jito koi amar bahut bacha usually chamberot ahe nakor awaz hudi koi sir mor bacha dhai hoise neki. So what you looking, Himanshu? Please explain.
Well, sucking well, sleeping well, no fever.
Yes, very good. So any role of ambroxol drop?
No.
Any role of cefixime drop?
No role.
Why?
Because
Yes, definitely baby sleeping well, sucking well, no fever. So our aim is to anxious parents only counseling, but with warning sign. Say yes, if any problem with not feeding well, fever is there, then you observe and you bring the hospital. I think, thank you, Himanshu. So anything nasal drop?
nasal drop only when there is
Yes, no. Is it required nasal drop? Yes. No, I think it is not a required nasal drop, because nasal drop is required when there is a nasal obstruction. Please mind you, now I have found from the hospital everyone prescribed nasal drop before feeding. So parents want every feeding they start giving nasal drop. So I don't know, audience, what do you want? Whether required nasal drop or not. Even hospital discharge along with vitamin D, they prescribe nasal drop. Is it, Himanshu, is good?
no, it's not good.
Is not good. So today onwards, please, nasal drop only prescribed in case of nasal obstruction. So there is why healthy children cough on average. So how will you explain, Himanshu? If you do not want to treat child is coughing.
Cough is a protective reflex.
Yes, good.
To activate the mucociliary reaction, and a baby can cough like 10 to 11 times a day.
Yes,
So it's
yes.
normal.
So yes, they are aware with some experience, even 30 episodes per day may cough, if not associated with other illness. So it can be observed in 10% of even preterm baby and almost up to 90% of full-term baby may cough up to 30%. So please ensure is that very important, so that baby breathing to downwards. So this is the main case. So our first case introduced in every dilemma that many of us face in early life. So health baby and these drugs are unnecessary and potentially harmful at this age. So I will proceed. So I told you cough is one of the most important protective reflexes, contributes significantly to the innate immunity of the respiratory system by enhancing mucociliary clearance. Already Himanshu explained, cough is under both voluntary and involuntary control. So no treatment required except nasal obstruction, then they will require nasal drop. So again I want to say this presents a very different scenario, a true clinical emergency in a young infant. This is my second case. A 3 months baby cough for 3 days, first episode of cough, fever up to 101, runny nose, irritable, respiratory rate 66, subcostal retraction. This is the chest X-ray of this baby. So, Dr. Swapnali, so you don't like.
Yes,
What chest finding you find in this case?
In auscultation.
In auscultation.
Sir,
in
in
3 months baby.
Yeah. Sir, in auscultation, there may be crepitations may be there, and
Which one is common? I am interested in. Krebs is common or Ronchi is common?
Ronchi is more common, sir.
Okay. Then
And sir, here in this X-ray, as we can see, this is a AP view of an infant
Yes,
X-ray.
yes.
As we can see, the lung veins are hyperlucent.
Yes.
Then there is widening of the intercostal space,
Yes,
which is very much suggestive because of hyperinflation. And the diaphragm is
Is
flattened.
flattened.
That is because of ongoing air trapping.
yes.
Most probably due to inflammation of the small airways, and this is typically seen in case of bronchiolitis.
Good. So, Sapnali,
Yes, sir.
why air trapping? Any air trapping cause subjective clinical finding, but any problem with, suppose there is a air trapping,
Yes, sir.
what clinical finding you will get in newborn baby? In this baby,
Bronchi will be there,
I think.
Yes,
I
sir.
think subcostal retraction.
and retraction will be
Yes.
there.
So subcostal retraction is the word honest where there is a air trapping. If there is a intercostal retraction, it is usually pneumococcal
Yes.
disease,
Yes.
pneumonia.
Yes.
And when there is a suprasternal retraction, it is a upper way obstruction.
Yes, sir.
So these are the clinical findings. Here I want to say Krebs is more. I think Krebs is more because of discommission of epithelial cell and there is a mucus secretion. But this Krebs does not mean child is suffering from pneumonia.
Pneumonia. Yes.
That is one important. So it does not mean that it is a pleural secretion. So here already explained by the chest finding very nicely. So what is the treatment? So I want to know the treatment of this child. Swapnali.
Sir, actually, bronchiolitis, as the name indicates, it's the inflammation of the airway, small airways in the respiratory system, mostly seen in infants. And here, mostly, this is not the causative agents are not bacterial; it is mostly viral. And
Any cough syrup?
No, sir. The suppurative care, that is oxygen. Suppurative care, that is oxygen support is more important, and rest supportive care. In mild cases, we can discharge the patient by proper counseling, but in case of if the infant present with severe RDS of moderate or severe, moderate to severe respiratory distress, then the new modalities of the treatment, that is HFNC or humidified high flow nasal cannula oxygenation, is very important and is very effective. It does not as such, it does not has to do anything with the disease, but it's a supportive care, and in especially in case of severe RDS due to bronchiolitis in pediatric intensive care, if we start with high flow nasal oxygen, we can at least delay or we can avoid intubation or mechanical ventilation.
What about the nebulized with hypertonic saline and bronchodilator? Any role?
Yes, sir. Actually, bronchodilators and 3% NaCl nebulization, it's not required in mild cases, but now in our day-to-day practice, we have seen that it has become increasingly many cases the nebulization with bronchodilators and 3% NaCls are going on, and even in some the parents, they do it self-treatment, which should be avoided. And if needed, if bronchodilators, if nebulization or 3% NaCl nebulization needed, patients should be hospitalized.
Yes.
And under observation, with oxygen, nebulization should be given.
So dear friends, nowadays every home nebulized with 3% normal saline, which should be avoided nowadays. At home, there is a complication of nebulizing. In emergency setting, we can nebulize in moderate and severe cases.
Yes.
So definitely there is a role, possible role of CPAP or HFNC. So dear friends, underlying pathology is mucosal edema and mucosal bulging. So it is not a bronchospasm. Yes, 1 or 2 trial of bronchodilator NS can be done. If improves, then we can continue to treat. Otherwise, oxygen is better. So best supportive treatment is hydration, nasal saline, and oxygen if requirement. Okay? Yes. Anything? Yes, if it is SpO2 oxygen level is less than 90%, then you will have to admit. Our moderate and severe cases. Yes. Yes. That's why you have to observe and admit the child. Yes. Yes. And investigate. Okay. Thank you. So next we'll go to case 3. It's a very good case. I think 2-year-old child. So nowadays day-to-day practice we have found such cases. So 2-year-old child cough 5 days, dry cough. Fever initially 3 days maximum, but presently afebrile. Bilateral bronchi, respiratory rate 36, running nose, slightly irritable. 4 previous similar episodes in last 8 months. In between episode, child become normal, no weight loss. So any diagnosis, Dr. Chow, any diagnosis, any TB,
Sir, the case 2 years old kids.
Yes.
And chest findings of bilateral bronchi wheezing,
Good.
borderline tachycardia.
Yes.
Maybe case of hyperactive pelvis.
So will you diagnose the case as asthma?
Most probable case of asthma. Sir.
Most probable case of asthma. Do you think child below 5 years will diagnose the case asthma with this history? Any audience? It is not asthma, it is a wheezing baby. Okay. Any? Okay. Agreed? Anyone? So how do you manage? Management?
Sir,
So first, management, anything you want?
in acute
Any cough
phase-
syrup, any bronchodilator syrup?
Sir, presently I think cough syrup should not be used. But
Yes.
a short trial of short-acting bronchial agonist, if symptoms subside.
But mother is very anxious whether my child is suffering from asthma or not. What will you say?
Okay, sir. If the symptoms subside, then we just have to observe the child for quite some period of time.
Yes. So it is actually under 5 vision. So whether you will write in prescription asthma or not. Audience, again I am asking. So see, this is the GINA guideline. I know GINA is not a Bible, but GINA given as a very good line. After GINA guideline, then I will ask everyone whether you can say asthma or not. See, recurrent acute wheezing episode. See, recurrent acute wheezing episode or at least one acute wheezing episode with asthma-like symptom between episodes. Second is no likely alternative cause for respiratory symptom like primary ciliary dyskinesia, like obstructive pathology or foreign body aspiration. Not family history. So ultimately, timely clinical response of respiratory symptoms or sign to asthma medication like short-term SABA within a minute, acute wheezing subsides, or more severe episode within 3 to 4 hours after SABA and OCS started respond. Short-term response to SABA even at home within a minute. Reduce frequency or severity of acute wheezing episode if symptom between episode within 2 to 3 months trial of intracortical steroid. So all three criteria is fit in this case, last case. So in my opinion, we can say it is a case of asthma. According to the JINA guideline, I am talking about the JINA guideline. I know JINA is not a Bible. So because all three criteria are needed for the diagnosis of asthma in children below 5 years and younger. So all three criteria is there. In my last case, you can see recurrent wheeze, 4 episodes, 1 episode of severe, in between episode in child is normal. So all three cases are needed for diagnosis of asthma in children and younger. Yes. If 1 or 2 symptoms are present, then previously JINA guideline says it is a probable asthma. Otherwise, if 3 criteria are fulfilled, it is a case of asthma. So I think we can write case of asthma or under 5 result. In that case, we have given the trial of intra. So why trial you want to give? Then we prove it is a diagnosis of asthma.
So usually if it is the case of bronchial asthma, the trial, the symptoms usually subside on the trial of SABAs.
Yes. If you trial of giving intracortical steroid and if child responded well, then we continue for 3 months. After stopping, if child is okay, that is a under risk. If it is continued, symptoms and signs, then we label as a asthma case. But suppose a child is 6 years old and presented these symptoms, then what is your diagnosis? So I think if we have to take the family history of triggering factor or asthma factor or then we can label without, after doing spirometry, we can label as asthma. So next, focus on a massive issue in daily practical care of routine prescribing of over-the-counter cough syrup. So this is a 7-year-old child cough for more than 4 weeks. What other information you need in history to reach the diagnosis? So I think Dr. Yasin Ali, please explain what is your diagnosis with this child?
So this is a cough, it's a chronic cough, more than 4 weeks, according to the ATS, American Thoracic Society. BTS says it is more than 8 weeks. We can go with the ATS. So we cannot have a straightforward diagnosis in that. We can have differentials. So cough more than 4 weeks, maybe a viral cough is prolonged. Maybe a case of tuberculosis, maybe a case of asthma, maybe a case of forgotten foreign body. So these are the upfront differentials we can think of. So to reach the history, we need to go through the history part very thoroughly. So how was the cough? What was the onset?
Yes.
Was it acute or subacute type of
So
onset?
assessment of cough is very important.
Yes.
Then you can level the diagnosis.
It's a dry type of cough, wet type of cough. Is there any diurnal variation? Any change with the posture? And is there an associated fever? If there is any weight loss? If there is any history of cough contact? So these are the things we will be going around and we will be asking about symptoms like that. If the child is coughing more during increased activities.
Suppose patient come with cough history. Now will you prescribe cough syrup on the first day?
No, actually not required. We will go to the underlying, find the underlying cause and then treat.
Yes. So we have to assess of cough in children. So we have to know the duration of the cough, quality of the cough, triggering factor, progressing of the cough, diurnal seasonal variation, neonatal history, environmental exposure in particular, or medication and analysis. So to come to the diagnosis, Yasin, anything to be done in this case?
So in this case,
After taking the history of cough and everything, there is no serious disease.
So in this case, more than it's a 7-year-old, more than 4 weeks of cough. So I would like to go for a spirometry first in this
Yes.
case.
So any IgE test required in the
Not
audience
required.
in this case? Any role of IgE level? So Yasin, anything?
So no role of IgE.
I think no role of
No
IgE.
role of IgE. In Indian context, it is more so because we are mostly exposed to these parasites, GI parasites. So our baseline IgE is always increasing.
So simple level of IgE does not say if your child is suffering from asthma or not. So before going to this cough, so I want to explain just chronic cough reported in 20% of the children from the area. We are defining the cough in the 3 pattern. There are 3 pattern type of cough where graphic presentation is there. So one cough is acute with delayed recovery. This is the green marking where there is a may present with acute with delayed recovery. Second one is recurrent, where there is a waxing and waning of the cough. And third one is a persistent non-remitted cough, which prospective study in Cape Town shows that if there is a persistent non-remitted cough, it may turn 10% cases, maybe a case of tuberculosis. So we'll have to know the pattern of the cough is a very, very important, apart from the assessment of the cough. Yes. So in this case, if you want to diagnose, we'll have to do the, I think, diagnosis for spirometry, is probable diagnosis. So chronic persistent cough, history is not from the caregiver. It should be taken by a doctor, detailed history from of the physician and to not merely by the caregiver. So we have to know the 3 basic pattern of the cough. So now you are allowed to do investigation. Do investigation, Rashi, or any audience. Which investigation you first prefer in the line of this?
So I would like to do only one,
Which one?
only spirometry.
Already we discussed spirometry. Nowadays is a good modality to exclude the asthma or no. So suppose I want more further spirometry than which second one you want?
So in this case, actually, chest X-ray on CBC, CRP, MD, PCR, not going to help.
But it give only suggestive.
Not going to help.
So-
So if there are some other things what we are expecting, such as maybe some congenital lung diseases which we have missed earlier. So structure we
Yes.
go for a HRCT test then.
So if it is a weight cough or suspected structural issue, chest X-ray or some kind weight cough molecular test may require. Otherwise, non-specific tests like CBC really change your management. So spirometry is the only reliable indicator in this case. So we go case by case. So that's why. So already we have mentioned there are 3 types of cases. So here. So we'll go to the next. Let's explore case 5 where highlights how a persistent dry cough can sometimes lead to an unexpected diagnosis. So I think one should see a 4-year child cough for 4 weeks, monophagic, wheeze, no fever, no response to intracorticosteroid or oral corticosteroid. One expiratory chest X-ray was done. So this is the chest X-ray finding. So Himanshu.
বাবু আমি পরে কথা বলছি একটা মিটিংয়ে রয়েছে পরে কথা বলছি
There is hyperinflation in the right side.
Yes.
The left side is the normal.
Yes.
So it may be a cause of obstruction to the one side.
Yes. So lack of response and single pitch beats should immediately make you think of what is the mechanical airway obstruction might be. Okay. And then there is a slight persistent cough over there. But why expiratory? Why not respiratory? One expression.
Because if there is a ball and valve mechanism of the foreign body
Yes.
intact, so while expiration that part will not deflate.
Visualize. Yes.
So
So the expression it might show normal X-ray sometimes. Suppose child below 2 years or below, we cannot do the expiration. Then what we have? How do you help in this case?
lateral penuncles we can do, and the dependent lung used to deflate.
Yes.
But if there is a foreign body, so there is
So what
chances
is the
that
modality of the treatment or diagnosis?
we will go for bronchoscopy.
Yes. So persistent unilateral breach post choking episode makes normal chest X-ray now. So most appropriate action, which one?
Bronchoscopy.
Why not CT scan chest? Audience,
Because of there may be some.
let's see, audience, which one is best modality? CT scan or bronchoscopy? Yes, CT scan does not show
Radiolucent.
radiology. Yes. Okay. So this is the sign of. So we have found one obstruction case which present as a acute presentation. So here there are chest 2020 guidelines classify cough into 3 types, where there is a normal or expected cough. Classification of type expected cough refers to cough illness reflective of common upper respiratory viral infection in an otherwise child where the cough duration is less than 2 weeks but sometimes may be prolonged. So this is the normal and expected cough. Now specific cough may be present, but there should be a presence of some abnormal physical finding like hemoptysis, like clubbing, like hypoxia, like pneumonia. So that is a specific cough. And another one is, sorry. A persistent dry, non-productive cough lasting for over 4 weeks without any identified underlying respiratory disease infection or abnormality. So it may be due to hepatic cough, it may be post-viral or basic cough. So we'll get 3 types of cough, non-specific cough. Okay. So there are 3 patterns we have done. So we'll go to the next. Now our focus to the evaluation and management of chronic bed cough. So till date we are present with acute and acute cough more than 4 weeks. Right? All are dry presentations. So Dr. Yasin, now we'll go to management of chronic bed cough. So a 4 years child suffering from prolonged bed cough for more than 4 weeks, cough moist, more at night, few scattered bronchi, increases with postural changes, and present with shortness of breath. Parents say some wheezing sound, diaphragm sound, nose breathing, hoarse rattler sound. Child is afebrile, but total count is 11,600. ESR is 20, CRP is high. So your goal and diagnosis, any again I want to say, you start with cough syrup or not?
Sir, with this history, sir, this is very classical history. Chronic cough with scattered bronchi, it's the wet cough, and there is increase with postural changes, along with there's rattling sound, ESR CRP high. So we are thinking of something infective. So most probably this is a case of protracted bacterial bronchitis.
Okay. So I have bronchoscopic findings and Dr. Yasin, can you explain this?
And along with this is very classic of PBB, this bronchoscopic finding. You can see purulent secretions there, some mucosal edema is there.
Yes.
And if we can go for a histopathology, we will see biofilm formation also in this case.
Yes. So this is very, very important, and I want to say there is no cough syrup in such cases. So we will have to diagnose, because this is the one of the disease which if leads, then it becomes irreversible bronchiectasis. So early diagnosis and early treatment is the best. Otherwise we will end up with irreversible. So can you tell, Yasin, explain slide a little faster, the types of PPB?
So the PBB, so different 4 types usually. So we can go from the history, then we go, it is called as PBB clinical. We will be diagnosing clinically without taking help of any investigations. That is 4 weeks of wet cough and without any other explanations of other conditions. So that is called PBB clinical. And we give 2 weeks of treatment and it does not resolve. Then we will be seeing that how much that this will level it as PBB extended, and we will be prolonging the antibiotics to 4 weeks. Then we will see if we can do a bronchoscopy. If we do a bronchoscopy and pick up the bronchoalveolar lavas and find the bug, then we will be labeling it as PBB micro. And the bulk should be positive, the CFP should be more than 10 to the power 4. And sometimes the PPP, even after treatment, it recurs. If it recurs more than 3 episodes in a year, then we will be labeling it as a PPP recurrent.
Okay. So I don't want to go. So there is a algorithm is there approach to chronic wet cough. I don't want to go individually. We can go separately. So I want to go to the next one. Yes. So Dr. Swapnali Borwa, highlight today this case 7 highlights the return of vaccine preventable classic in a underutilized infant. So let's see what is the problem. So is the 4 months male gradually increasing cough, short prodrome of runny nose, mild fever 10 days back, no other family history suffering from cough, and received 1 dose of DPT and IPV.
Yes, sir.
So what is your any clue for diagnosis? Or
Sir,
I think
first we shall have to focus at that is the age of the infant. It is 4 months.
Yes.
So the vaccine, the routine national immunization routine
Should be
vaccine
completed by this time.
yes. So it is whether it's completed or not. And its second is that it is gradually increasing with some cataract symptoms like prodromal symptoms like running nose, mild fever 10 days back. And another very important is that the patient has received only 1 dose of DPT.
So yes, continue.
So the vaccination is incomplete as per the
So what is your
baby
likely diagnosis there?
So and the X-ray findings is near normal. So it's most likely vaccine preventable diseases like pertussis.
So nowadays we are finding so many pertussis cough.
Yes.
So almost even adenovirus also causes pertussis cough. So confirmatory diagnosis is always PCR.
Yes.
So here it is a Bordetella pertussis. This is a confirmed case. So this is a case of whooping cough. Video I don't know whether it run or not. Pariva negative. I want to show you the baby is coughing with whoop. Usually we do not found nowadays whoop. Usually found all cases of pertussis.
Dr. Nirmal, you have got 5 minutes more.
So I think so it cough with a so I want to go fast to one acute emergency cases where in day-to-day practice we found in so there is a non-specific cough with present with rhinorrhea, coryza, fever, abrupt onset of barky cough, hoarse voice, inspiratory started during the night, and yes, I want to know Dr. Chow. So what is your likely diagnosis?
Sir, first thing it's like 2-year-old child
Yes.
with the onset of barky cough and rhinorrhea and coryza and inspiratory style movement. Points towards group.
Good. Okay. So any positive organism?
Mostly viral, sir.
Viral. So anything you want to investigate the child?
Most of the time it's just a clinical
Why not?
diagnosis.
Why don't you want investigation?
Investigations are
Because it is an acute emergency. We have to treat the child. Otherwise, we may end up with respiratory failure. So here there is no cough syrup, no investigation. We will have to treat the child immediately. First, we will have to treatment before going to what treatment you want to give. Here.
Sir, first we maintain the vitals, sir, the circulation. And respiratory failure should be prevented. Maybe if it is mild
First, we have
case,
to maintain the ABC. And treatment is actually dexamethasone, which should be given at single dose 0.6 milligram per kg, IM or IV or even oral route. Sometimes study was done dexamethasone 0.2 mg also. Later on, if not respond, then we can do inhaled budesonide. First, we'll have to diagnose mild, moderate, or severe. So I already a mild case without stridor, moderate case with stridor, and severe case with agitation. So almost moderate, severe case required observation in ICU. So the case 9 I have not given to other panelists. This is a very interesting case which I have found. So I want to go through, and audience is the help me in the diagnosis. So a 4-month, 26-day child with came to me like 8 May 2024 with history of 2 months cough and cold. Baby is on mother's milk. Weight, height, everything is okay. Birth history is normal. Birth weight is normal. Immunization history completed. Exclusive breastfeeding. Developmental history normal. On 10th April, he was admitted in medical college with weight 6.4. Diagnosis pneumonia. Amoxicillin, ethylene nebulized saline nasal drop, and discharged with 17 April. So next case on 20th April, again patient came to the same hospital for checkup and referred to another medical college with a history of on and off cough, post-acid vomiting, apparently well child. Later on experienced whoop-like cough also. Investigation was done. Nasal throat swab was done. Throat swab culture done. Chest X-ray done. Even chest X-ray, CT scan was also done. So it shows acute pulmonary diagnosis. Treatment ethylene nebulized, vancomycin, azithromycin agent. On round advice EEG, echo, ENT call, bronchoscopy advice, refer to ENT for bronchoscopy, refer to pediatric surgeon. Ultimately, supporting treatment at death and bronchoscopy was done. Patient was discharged against with tickets, and he came to me at night on 5th May, and he came to me. So what was this here? A very interesting case. Infant present with persistent pneumonia that fails to respond to standard broad spectrum antibiotics twice. You must systematically evaluate. So what was missed here? Any panelist want to discuss? A simple investigation before going to chest X-ray and bronchoscopy. Anything? Audience? Yes? GRD. Okay. Before that, so let's see. I know everyone means, but think systematically. Some cases are required. It may be a case of a typical infection. It may be a case of virus. It may be. See, because this case came, and on the round next morning, I just advised on ultrasonography and chest X-ray repeat. X-ray was normal. On day CV not testing, it was done in baby room where baby was kept nil orally for 2 hours. Then 2 ml gastric fluid was aspirated and sent for test. Yes, that's positive.
Thank you. Nirmal, can you kindly down?
Yes, I want to. This is a very interesting case. So that's why I done CV done. On doubt, because child is well thriving, weight is okay. So I have a doubt. Then I did next day after 24 hours. Again I sent a gastric X-ray to another lab. Here also is the MP positive. So this is very, very important. This is positive, it is detected trace, but rifampicin resistant indeterminate. See, it may be a case of resistant rifampicin. So that's why after so much investigation, a simple investigation before going to chest X-ray, I want to highlight, at least don't forget in children to do CVR. Because gastric aspirate is very easy rather than expected cup. That is my aim to progress. So this is the algorithm of, I don't want to go in detail, that is found in the textbook.
Thank you.
See, I have done the parents chest X-ray, this is normal. I don't know whether exposure, there is no exposure history. Even I have done the chest X-ray of both parents. Then I left the case. So I don't want to go common causes of dry cough, common causes of weight cough.
You can have discussed
Just
later.
finishing.
Yeah.
So
please.
I don't want to go in details. There are so many, but one cough syrup nowadays, levodopa, which is a now peripheral, non-opioid antiseptic, suppress cough by acting directly on tracheobronchial sensory receptor rather than central nervous system. To work on inhibitories. So this is the only, but nowadays this product is not available. We have lacking of robust evidence of using steam inhalation, oil massage, herbal, but honey probably reduces cough duration. There is no strong evidence against using honey. For acute cough, throat soothing agent like warm water, saline gargle is there. So management of cough is hydration, honey, nasal drop, inactive OTC cough syrup, bronchodilator, oral decongestant, antihistamine, controversial cough suppression, mucolytic, antihistamine, and symptomatics, lower this one. Market of cough syrup, 21,800 crore in 2024. Cough syrup marketing. So there are 1,000 of khichdi cough syrup available nowadays. This is a holy mixture of group syrup. So my conclusion, reassured normal reflexes. A occasional cough in an otherwise healthy newborn is normal physiological airway clearance reflex. Supportive care for bronchiolitis is required. Rule out foreign bodies, any persistent dry cough. Identify and treat protected bronchial bronchitis because it's an irreversible bronchiectasis. So you require evaluated tuberculosis early. In high burden setting, persistent cough, fever lasting more than 2 weeks, significant weight loss require upfront chest and molecular testing on gastric aspirate or sputum specimen. Avoid multi-ingredient OTC over-the-counter pediatric cough syrup, lack proven clinical benefit, carry risk of serious advancement in young children and should be replaced with simple low-risk supportive care. Thank you. Perform your obligatory duty because action is
Thank you, Nirmal.
Sir, first thing I want to give
Thank you,
Dr.
Jain.
Raj for providing the platform of latest disease about the respiratory and our four panelists. Many thanks and many thanks to the audience.
Thank you, Nirmal. You have done wonderful. Only time maybe you will need around 5 minutes. Anyway, all the panelists are there. We are very good. And this is an eye-opener for us also because we are doing practices class. These are things we miss sometimes also. Thank you very much. Thank you. We round of applause for all the audience. Thank you very much. Thank you.